Welcome back to The Explainer. Today we are taking a really fascinating clinical deep dive into the complex neurological presentations of posterior fossa and brainstem syndromes. We've got a lot of dense neuroanatomy and pathology to get through, but don't worry, we're going to break it down point by point so it makes perfect clinical sense.
Here is our agenda for today. First, cerebellar mutism, the basics. Second, CM pathophysiology and treatment. Third, classic brainstem syndromes. Fourth, defining Perinaud's syndrome. And fifth, Perinaud's differential diagnoses.
All right, Section 1, cerebellar mutism, the basics.
Let's get right into it. To define it clearly, cerebellar mutism, or CM, is literally a state of speechlessness that develops after an injury to the cerebellum. Now, if you're digging into the literature, you might also see this referred to as mutism with subsequent dysarthria.
So what actually causes this sudden loss of speech? Well, it can absolutely be triggered by things like cerebellar trauma, an ischemic stroke, a hemorrhage, or even viral cerebellitis. But here's the key takeaway. It is most frequently encountered in children right after the surgical removal of posterior fossa brain tumors.
Now, the clinical reality of CM's prognosis is, well, it's pretty stark. The good news is that the condition essentially always improves over time, meaning, the patient won't remain completely mute forever. But, and this is a big but, their speech almost never goes entirely back to its baseline normal. There are almost always lingering effects.
It's absolutely vital to understand how CM fits into the broader clinical picture. See, CM can occur in absolute isolation, but cerebellar mutism syndrome includes the mutism plus a SIP, ataxia, hypotonia, and irritability. Now, look at how posterior fossa syndrome builds directly on top of that. It takes all of those symptoms and then adds cranial nerve deficits, neurobehavioral changes, and urinary incontinence or retention. It's like stacking building blocks of clinical science.
And that brings us to a crucial clinical distinction. Cerebellar mutism is explicitly not considered a component of standard cerebellar syndrome. Classic cerebellar syndrome is defined simply by three things: ataxia, dysmetria, and nystagmus. Make sure you keep those definitions strictly separated in your mind.
Looking at the epidemiology, the numbers are kind of mind-blowing. Cerebellar mutism has a massive 53% incidence following surgery for medulloblastomas in children. That drops to 33% for ependymomas and 11% for pilocytic astrocytomas. We know for sure that brainstem involvement and a midline location act as major risk factors for this complication. To put that into perspective, while this is highly prevalent in pediatric cases, post-op CM is seen in only about 1% of adult cases following posterior fossa surgery. Just 1%.
Let's isolate the clinical timeline here, because it's uniquely characteristic. The onset of CM is typically delayed. It doesn't usually happen the second the patient wakes up from surgery. Instead, it appears on average 1.7 days post-operation, though honestly that window can range anywhere from 1 to 6 days after the procedure.
The period of absolute mutism itself has a limited duration, lasting an average of 6.8 weeks. But that comes with a really wide range, from just 4 days all the way up to 4 months. And remember what we discussed about the prognosis? Long-term linguistic sequelae persist in an overwhelming 98.8% of these patients.
Moving on to Section 2, CM, pathophysiology and treatment.
So what exactly is happening in the brain to cause this delayed, persistent mutism? Well, theories like postoperative vasospasm, cerebellar ischemia, and transient edema definitely exist in the literature. But the most widely accepted explanation right now is cerebellar diascasis. Diascasis comes from Greek, meaning shocked throughout. It refers to a metabolic shutdown or hypofunction in a completely distant cortical area that's caused by the disruption of connections to the injured area. Specifically, injury to the dentate thalamocortical tract disrupts the cerebello-cerebral circuits. In fact, SPECT scans have actually shown reduced cerebral perfusion in the frontal, parietal, and temporal cortices of these patients. So the cortex itself is structurally intact, but functionally, it's shocked.
Unfortunately, when it comes to treatment, our options are strictly limited to supportive measures like intensive speech and rehabilitation therapy. On the prevention side, some surgeons suggest avoiding midline splitting of the cerebellar vermis, for instance, by using a televelar approach to the fourth ventricle. However, the study results are pretty conflicting, and currently, no universal surgical recommendation actually exists to definitively prevent CM.
Okay, Section 3, classic brainstem syndromes. Now, notice the patterns in these classic lesion locations. It's like a clinical puzzle.
Both Weber's and Benedict's syndromes feature third cranial nerve policies and contralateral hemiparesis. But Benedict's is unique. It features arm hyperkinesia, ataxia, and a coarse intention tremor, because the lesion extends into the midbrain tegmentum and involves the red nucleus. Meanwhile, Millard-Gubler syndrome is situated way lower, in the base of the pons, usually from an ischemic infarct, so it completely bypasses the third nerve, and instead causes ipsilateral facial and abducens nerve policies. That's cranial nerve 7 and 6, alongside the contralateral hemiplegia.
Next up, Section 4, Defining Paranod Syndrome. Let's move into our final major anatomical region, the dorsal midbrain, and a fascinating condition known as Paranod syndrome. It goes by a few names, actually. You might see it called dorsal midbrain syndrome or pretectal syndrome. It was originally described and is classically defined as a supranuclear paralysis of vertical gaze caused directly by damage to the mesencephalon.
We're going to break down the clinical signs one by one because each is a vital diagnostic clue. The primary hallmark here is an upward gaze palsy. This paralyzes voluntary upward saccadic and pursuit tracking. But fascinatingly, because the neural pathways are different, it spares horizontal eye movements and it spares the vestibuloocular reflexes, which you probably know as the doll's eyes reflex. The second core sign is lid retraction, clinically known as Collier sign. Imagine a patient with a retracted upper eyelid, combined with the absolute inability to look up. Their eyes naturally appear driven downward. This creates a visually striking clinical presentation famously called the setting sun sign. The third and fourth typical findings you really must look out for are convergence palsy and accommodation palsy. These findings just further highlight the extensive disruption of the highly localized visual control centers that are clustered right there in the dorsal midbrain.
You should also be super aware of several less common associations that can pop up alongside the classic signs. Things like pseudo-abducens palsy, seesaw nystagmus, fixed pupils, or a pseudo-Argyll-Robertson pupil, convergent spasm, nystagmus retractorius, and even internuclear ophthalmoplegia, or INO. There are also a couple of specific variants to keep in mind, a unilateral variant called a skew deviation, and the syndrome of the Sylvian aqueduct, which is essentially just paranods combined with a down-gaze palsy.
And finally, Section 5, Paranod's differential diagnosis.
So, what's actually causing all this midbrain damage? True Paranod syndrome is typically caused by physical pressure or destructive damage directly to the quadrigeminal plate. Clinically, this is most commonly seen from pineal region masses pushing downward. It can also be caused by elevated intracranial pressure, like from hydrocephalus, where the dilated suprapineal recess physically compresses the mesencephalic tectum. Other etiologies include an upper brainstem stroke or hemorrhage, demyelination from multiple sclerosis, or even occasionally infectious etiologies like toxoplasmosis. But before you definitively diagnose a structural midbrain lesion, ask yourself, could this just be a mimic? You absolutely must rule out systemic conditions affecting ocular motility like Guillain-Barré syndrome, myasthenia gravis, botulism, and hypothyroidism. And hey, never forget the gradual benign loss of upgaze that just naturally associated with normal aging. Meticulous clinical correlation is everything. So, the next time you see a complex ocular palsy, which of these neurological puzzle pieces will be the key to your diagnosis? Keep analyzing, keep localizing, and I'll catch you in the next explainer.